Hi.
Hi. Okay, do you have your hand out for heart failure? Please get that out. Okay, who can tell me what the four pillars of treating congestive heart failure are? Okay, right. You're trying to decrease, trying to prevent remodeling. So you do that by decreasing preload and decreasing afterload. Preload, that's what comes into the heart. Afterload, that's what the heart is pumping against. That's essentially the systolic blood pressure you're pumping against. So the first pillar is beta blockers, specific beta blockers. Which ones? Okay, not just metoprolol, but sustained release metoprolol. So sustained release metoprolol. Which other one works in congestive heart failure? Bispropolol. Bispropolol is very heart specific. And what's the third one? Sorry? Carvedilol, right. So carvedilol has this alpha-1 inhibition. That alpha-1 inhibition is going to cause vasodilation. So in addition to the beta-1 inhibition and also beta-2 inhibition, this is going to slow down the heart rate. This is going to also cause vasodilation of capillary beds and vessels in the lung, capillary beds in the brain, other visceral organs. This will also drop systemic vascular resistance. This will drop systemic vascular resistance in, that's a V, peripheral circulation. Carvedilol is a very good drug for heart failure. So beta blockers. Beta blockers are essentially a must. Okay, pillar number 2. Right, something to inhibit so the renin, angiotensin, aldosterone system. So you can use either an ACE inhibitor or more commonly now people are using Entresto. Entresto is oral. It's a combination of what two drugs? Valsartan. What's valsartan? What kind of drug is valsartan? a sartan. It's a angiotensin 2 receptor blocker. Angiotensin 2 receptor blocker. Why are we so thin on the ground today? Where is everyone? Okay, so Abby's coming. Speaking of which. Yeah, Emma's in the Zoom, but then we're missing Haley. We're also missing, yeah. And Morgan. Morgan doesn't have a game as far as I know. Basketball's done, so. If someone has their number, text them. See if they're sick, I understand it, but the only one I heard from was Emily. And Emily's with us right now on Zoom. Everyone wave to Emily. She waved back, so. All right, so valsartan, and what's the other drug in Entresto? Sacubitril. Sacubitril is a neprilysin inhibitor. It inhibits neprilysin. So we're going to go neprilysin and then go like that. Now, some of the peptides, neprilysin, yeah, Sydney? I'm glad you asked. So neprilysin degrades peptides. It's a peptidase. And there are peptides that are very important for control of the heart and control of blood pressure. And in particular, you have the atrial natriuretic peptides. Do you remember those from A&P? Yeah, there's 3 of them. Well, there's more than 3 of them, but there's 3 main ones. Yeah, so there's when the atria gets stretched, the atrial myocytes secrete atrial natriuretic peptide, but then there's a so-called B-type natriuretic peptide. There's also a C-type natriuretic peptide. Then there's a natriuretic peptide that's actually made by the kidney as well. And neprilysin degrades all of these. Degrades all of them. By inhibiting neprilysin, so these not only vasodilate, these oppose the activity of angiotensin 2, they also cause diuresis. So they cause you to lose more water, lose more sodium. That's going to further drop your preload. So neprilysin will allow the atrial natriuretic peptides and the other natriuretic peptides. Natriuretic, what does that mean? Emily, I'm sorry, I'm not used to seeing you with glasses on. You look like a college professor with those glasses on.
These ones are new. They're a little bit more professional.
Oh, they look a little more professional. Oh, okay. Emily said she's giving me her professional look. So, sorry? That's exactly right. Increase sodium secretion by the kidney. That's natriuretic. Natri, sodium, uretic in the urine. So by increasing the activity of these, you decrease preload and blood pressure even more. And this is your go-to drug more and more these days for people with heart failure. The research on this is, every study that comes out basically says this stuff is great. So you will see this used a lot in your practice, probably. It's Entresto. I have no idea when I have a feeling once the patent runs out, they'll still call it Entresto, but that's the case. Okay, so that's pillar number 1. Pillar number 2, what is pillar number 3? There you go. There you go. Good. So you're usually going to want to decrease the activity of, so So this is very new. Introducing for heart failure, people would have said, it's a bloody diabetic medication. What are you doing? You're giving patient drugs they don't need. Then it turned out that these drugs really helped the heart function of diabetics. And so people said, well, they work for diabetics, let's give them to non-diabetics. And they dropped hospitalizations, they dropped deaths in non-diabetics. So these now have become part of one of the pillars of treatment of congestive heart failure. So these include, they end with gliflozin. So there's Cana, gliflozin, and gliflozin, and dapagliflozin. These are new drugs that are kind of expensive, but if your doctor prescribes them, insurance will pay for them. This is, oh good golly, Invokana. This one I think is Jardiance. And this one is Farxiga. Farxiga. Have you heard of these before? No? The Farxiga, if you go to the gym sometime around when the sports teams invade the place and throw everyone else out, they get these commercials on ESPN for these. And it shows people jogging and stuff like that. And then you can go farther with Farxiga, which, hey, as jingles go, isn't a bad one. But that's the, when you see these, that look for the gliflozin. So they increase urine production, so they increase the flow of glucose, because you're going to get more glucose in flowing out of the urine. So gliflozin, make sense? If you think that way, you see that at the end of the name, that's what these drugs are. That's what these drugs are. And we'll see these again when we cover diabetes, but they're starting to be used now for congestive heart failure. Again, this is new. This is new, but the guidelines were revised and that's what's coming up. Okay. Pillar number 4. There you go. So you want to inhibit aldosterone. You want to inhibit aldosterone. So not just potassium sparing, but one that inhibits aldosterone. So there's 2 of them. What are those 2? Spironolactone and eplerenone. Good job. Good job. Okay, so potassium sparing. Particularly aldosterone antagonists. So that will include spironolactone, and then eplerenone. All right, that's what we covered last time very quickly. Any questions, Sydney?
So, as a doctor, they would put them on one of these at a time or all together?
You'd put them on all together, but you start at very low doses, and then you'd start to crank them up according to how well they responded.
So, is there a point you have someone at a higher dose of a beta blocker, but at a lower dose of, say, or do they all gradually rise?
It depends. Some people are very sensitive to beta blockers, and so they respond very well at very low doses. That's one of the reasons why metoprolol, the sustained release, seems to be the way to go, because the sustained release essentially will give you a constant supply of the drug at a relatively low dose. it'll do its job and you don't make the heart beat any more slowly than it has to. Same thing with bispropofol. Bispropofol is so potent for the heart, you can use low doses of that and it usually works fine. Carvedilol, same thing. Usually with carvedilol, typically when you start someone on carvedilol, they're going to be really dizzy. So you may want to start them on that and then start them on the other drugs later in cases like that. Different cardiologists will have different ways of doing these. Some people say, oh, heck, just bite the bullet. Here's the meds, just take the meds. You'll feel like crap for 2 weeks, but you'll adapt. Others, no, let's layer on this. The issue with beta blockers is that some people, when they get on them, the heart rate goes really, really low. And they just can't shake the fatigue. So you really have to gauge people's response to it. The beauty of these is that if one doesn't work, you can try another one. And it's clear from the literature that all three of them work. But they have to be on one of them pretty clearly. All right, now, we started to talk about digoxin. And I don't think I told you, this comes from the digitalis plant. Some of you may, in your gardens at home, have foxgloves. They're biennial plants. When they come up the first year, they look frankly kind of ugly. They're just these kind of boring leafy things. Then the next year, they make these gorgeous spikes of flowers. Another name for them is 4 o'clocks. That, no gardeners in here? Anyway, the Latin name for the foxglove is digitalis. And so a digitalis extract contains essentially digoxin. Digoxin. All right. Digoxin is meant to increase the force of contraction. So it increases contractility. This is not used for acute heart failure. It's used for chronic heart failure. As we said before, digoxin has a narrow therapeutic window. And we talked about very briefly how it works. Do you want me to go through that again, or do you think you understand how it works? Just go over it again, okay. I'll get it later. All right, so. All right, Redan, that's a cardiomyocyte. So you have in the cardiomyocyte, you have a sodium, potassium ATPase. It's going to pump 2 potassiums into the cell, and it's going to pump 3 sodiums out of the cell. This is a component of virtually all cells. The enzyme is slightly different from cell to cell. That's why you can get drugs that will inhibit this enzyme pretty robustly in one cell type, not so robustly in other cell types. You will also have another protein sitting in the membrane of cardiomyocytes. And this is the calcium sodium transporter, the calcium sodium transporter. So this will take sodium and exchange it, well, 2 sodiums actually, for calcium. So the point of this, number 1, is to unload the cell. That's hard to see, isn't it? is to unload the cell of sodium, but also to increase intracellular levels of calcium. Now, digoxin is going to inhibit the sodium potassium ATPase. By inhibiting the sodium potassium ATPase, sodium levels are going to increase. Because sodium levels increase, they provide more sodium for the sodium calcium transporter. Therefore, more sodium is pumped out by this transporter. Therefore, you get more calcium inside the cell because of this. This increased calcium inside the cell does two things. It increases calcium release from internal stores of the cell. So remember the cell, the sarcoplasmic reticulum, stores calcium. This will cause more calcium release. That increased calcium release is going to increase contractility, because remember, the myosin actin machinery works by means of calcium. It's calcium that frees the tropomyosin from it binds to troponin, pulls the tropomyosin off the actin so that now the myosin can bind to the actin. So this increased calcium, you get more internal calcium release because of calcium-dependent calcium release, and therefore you have increased contractility. Now, digoxin has a second effect in the heart. It also inhibits the sodium potassium ATPase in vagus nerves that innervate the atria. Because of that, it increases vagal input to the heart. Now, vagus nerve input to the heart does what? Vagus nerve is which branch of the autonomic nervous system? Stunned silence. Parasympathetic. Parasympathetic to the heart, input to the heart does what? Slows it down. So the heart rate is going to go down as well. So you get increased contractility, but decreased heart rate. Consequently, the effects of digoxin with respect to heart rate will be mainly in the atria, because the vagus nerve tends to innervate mainly the atria. Does that make sense? So digoxin is a good drug for atrial arrhythmias. For example, atrial flutter or atrial fibrillation. It's good for that. It's not good for ventricular arrhythmias because the vagus nerve tends to innervate mainly the atria. All right, you guys with me? then, if you are with me, I will continue. All right, let's look at digoxin. So your levels have to be between 0.5 to 0.9 nanograms per mil. Those are the levels. The issue is that some other drugs, particularly heart drugs, inhibit renal elimination of digoxin. So for example, quinidine inhibits renal clearance of digoxin. So does verapamil. And so does sotalol. And others as well. So some drugs, heart drugs in particular, reduce the renal clearance of digoxin. So you have to watch for DDIs if they prevent clearance, because they're going to cause digoxin levels to soar. Now, because digoxin prevents potassium from getting into the cell, what do you think it does to potassium levels? Potassium levels go up with digoxin because it's preventing potassium from getting into cells. So you're going to watch that potassium like a hawk. That's one of your biggies with digoxin is potassium. Watch that potassium. Secondly, digoxin can cause some pretty sizable GI disturbances, and they don't necessarily go away. So that's nausea, vomiting, diarrhea, constipation, that sort of thing. Tends to mess with your GI tract. Digoxin can also cause arrhythmias. So you want to make sure that the ECG is regularly monitored. Also, because of the hyperkalemia, the hydration status of your patient can really affect what digoxin does to potassium levels. So essentially, dose the patient according to their usual hydration, then please beg them not to go outside or inside those levels of hydration. Now, digoxin is very lipid soluble, so it crosses the blood-brain barrier. So it also causes neurologic adverse effects. So it can cause confusion. It can also cause dizziness. And then it also causes something called xanthopsia. Xanthopsia means everything looks yellow. And a regular color blindness test can essentially tell you if that's the case. Also, people will complain about things looking yellow, and They may make comments about, oh, that's a nice off yellow you're wearing or something like that. That's another issue you see with digoxin. Digoxin can also cause conduction disturbances in the heart. So I can't stress watching the EKG enough. If digoxin levels get too high, what do you use to treat digoxin toxicity? Anybody know? Sorry? Right, Digibind? That's an antibody. And also another drug that can treat digoxin toxicity is lidocaine. Beauty of lidocaine, virtually every hospital has it. Once you give it IV, it works fast. Works very fast. Lidocaine, unfortunately, is also lipid soluble, can cross the blood-brain barrier, and can cause people to go a little cuckoo. But at least our heart is fine. Right. Digibind is available also. Usually, if hospitals use digoxin, they have Digibind as well. All right, so that again, digoxin is for chronic heart failure. It's not used for acute heart failure. All right. Now, what about acute heart failure? If you need essentially the heart, say you're trying to bridge someone, say someone has heart failure, they're going to either get a heart transplant or they're going to get some sort of mechanical augmentation. Say they're going to get a VAD or something like that, ventricular assist device, what have you, you're trying to bridge them. Then you can use acute sorts of things to bridge them to that. There are two drugs that are typically used for that. One is dobutamine. And dobutamine's on your handout, I believe. What? Oh, okay, under digoxin, good. Dobrex, I think, is the name of this. This is used a lot in ICUs for cardiogenic shock. I think Dobrex, is that the? I don't have it, okay. I think it's Dobrex, but I could be wrong. So this is a beta-1 agonist, but it also has some beta-2 agonism. Now, this is an unusual beta-1 agonist for this reason. This drug only increases the heart rate a little bit. So it's not like dopamine, where dopamine, especially at the high dose, dopamine will cause your heart to jump out of your chest. Your heart will beat so fast. This will increase the heart rate just a little bit. What this really does is it increases contractility. And that's one of the beauties of this drug, is you get increased contractility, and with the beta-2 agonism, you're going to get some vasodilation. That's going to decrease the afterload. And what does this do? This essentially is going to allow you to provide, to let the heart feed those tissues that it's having a hard time feeding. Now, when you use this drug in the ICU, you typically don't titrate it. You have a set dose, you usually just give that dose, and you don't really need to titrate it. But this is a very good drug essentially for trying to bridge people, or if you're just really trying to get the heart restarted, as in the case, oh, the other thing you use it for is sepsis. Because with sepsis, your pressure crashes and you can start getting end organ failure because you're not essentially perfusing organs. In fact, the international sepsis standards now recommend dobutamine for use in sepsis. It's proven to be so effective for that. So that's dobutamine. It's a beta 1 agonist. If you look at the structure of it, in fact, you can see epinephrine in the structure, and it's got this other business attached to it as well. So it's kind of epinephrine wannabe, kind of, I guess. All right, so that's dobutamine. Another drug is Millerone. Don't think I spelled that right. It's how do you spell it? How do you spell it? I don't think that's right. It's not going to be on here. Yeah, Milrinone. Thank you. Okay, let's try that again. Milrinone. There. Better? Milrinone. Milrinone. A mnemonic for this one is a millionaire rhinoceros. Milrinone, millionaire rhinoceros. Ellie, do you know Hope Noter? Yeah. Teammate of yours? She's in my other farm class, and I try out these mnemonics, and Hope just sits there and just shakes her head. She doesn't know what to do with me. So I try to get her to laugh, and she's just, no, this is dumb. This is dumb. But hey, she remembers it. So sometimes you remember what's dumb. So, okay. This is a phosphodiesterase inhibitor. Now you're probably sitting there saying, golly gee willikers, that just really warms the cockles of my heart. Phosphodiesterase breaks down cyclic AMP. Oh, what page is it on? Bottom of page 3. Bottom of page, I don't have my handout with me, so that's why I'm derelict. I'm sorry about that. Emily, bottom of page 3. So phosphodiesterase, so you see that ACE at the end, so it's an enzyme. This will degrade cyclic adenosine monophosphate. Now this is a second messenger. This is made in response to norepinephrine and epinephrine. So if you prevent the destruction of cyclic AMP, you are going to get more bang for your cyclic AMP buck, aren't you? So because of this, you're going to increase contraction, and you increase vasodilation. And in blood vessels, it's going to prevent the breakdown of cyclic GMP, which is a vasodilatory messenger in the smooth muscles of blood vessels. So you increase contraction and you decrease afterload. So you kill 2 physiological birds with 1 pharmacological stone. Ooh, that worked out well. And this is again going to give you good treatment for acute heart failure. Good treatment for acute heart failure. You don't use it in chronic heart failure. If you use it in chronic heart failure, it increases morbidity and mortality, but it's very good for acute heart failure. So the two arrows in your quiver for acute heart failure are going to be dobutamine and milrinone. Dobutamine and milrinone, Shay? Um, if your patient is on a lot of vasodilators anyway, milrinone is probably not going to give you as much benefit as dobutamine. So if your patient is less vasodilated, depending on what your patient's on, then they'll probably benefit more from dobutamine. In which case, if they're not on very many vasodilators, they probably benefit more from milrinone. So that is going to really be up to the provider based on what they work with and what they think will work. Some hospitals too will tend to use one over the other. They'll restrict dobutamine. In fact, there was one hospital in Pennsylvania. They didn't use dobutamine for acute heart failure because they wanted to spare it for cardiogenic shock. Because this was Temple Hospital. I don't know if you know anything about Philadelphia. Temple's in North Philly, and another term for North Philly is hell. It's a very, very bad neighborhood. Temple has the #1 trauma unit in the nation. You know why? Because they get a lot of gunshot victims. There's a lot of shootings, a lot of car wrecks, a lot of people coming and beaten up, a lot of gang violence in North Philly. It's really awful. But so because of that, they have a lot of cardiogenic shock. So they spare the dobutamine and they don't use it for heart failure. They just use milrinone. But that's their policy because they want to spare the dobutamine. So it's going to depend. Okay. Now, for milrinone, you're going to watch for arrhythmias. And you're going to watch for hypotension. Watch for hypotension. Dobutamine. Look for palpitations. Palpitations. There's a risk of tachycardia, but it's not. Doesn't occur often. So just watch for it, but it doesn't happen very often. Dobutamine, tachycardia, but it probably won't happen very often. And dobutamine also can cause arrhythmias. All right. I think I've hit just about all the medicines on that handout. Dopamine and dobutamine, nurses often confuse those because they sound kind of the same. And truth be told, the dose is about the same. So here's the difference between dobutamine and dopamine. Write this down. Dopamine has let me get here so Emily can hear me. Emily, write this down. This is important because nurses confuse dobutamine and dopamine because they sound similar and their dose is about the same. Dopamine has two different activities at two different doses. If you give a dose below 10 milligrams, it's going to be mainly a beta-1 agonist, and it's going to increase heart rate. It's going to increase heart rate. Whereas dobutamine doesn't increase heart rate that much. Dopamine is going to increase mainly heart rate. When you get above 10 mgs, now you also start to activate alpha-1 receptors. What do alpha-1 receptors do? They cause vasoconstriction. So now your systemic vascular resistance is going to go up. So that's an important difference between dopamine and dobutamine. Dopamine will raise your heart rate, but it's also going to increase the afterload. Dobutamine will not increase afterload. And it doesn't increase heart rate that much, but it increases contractility, whereas dopamine doesn't really increase contractility. Does that make sense? Dopamine increases heart rate, and at higher doses, above 10 mgs, it also increases afterload. So it increases systemic vascular resistance. So those two medicines are not interchangeable. Even though the doses are really similar. Dobutamine, I think, is like 2 to 10 mgs. You can go up to 20. Dopamine, I think, is 2.5 to 10. And then you can go up to 25 or something like that. So the dosages are really similar, but those drugs are not interchangeable. Not interchangeable. So if you hear dopamine, check it just to make sure you didn't hear dobutamine. That's why a lot of nurses will use the trade name for dobutamine so they don't confuse it with dopamine. I think it's Dobrex, Dobibrex or Dobrex or something like that. Dopamine. Yeah, amtropin is dopamine. Dobutamine can be given peripherally or it can be given via central line. So it's not like epinephrine that you virtually always give with a central line, or excuse me, preferably give with a central line. It can be given peripherally. Dopamine you prefer to give with a central line, but it can be given peripherally, but it's preferentially given with a central line. Okay, Mickey says it's time for the break. So I think we're done with heart failure. I'll tell you what, we'll come back. I'll entertain any questions you have, and then we'll go to antiarrhythmics. Okay, let's take 5 and stretch and yeah. Break time in, 5 minutes. Smoke if you've got them.
How's your outfit today, Jeff? That's been best.
Stacy likes bright colors. Anything that's a bright color, she's not. And then I've got some incredible news. And you,
Oh, my sister.
you're going to be Auntie Anna.
Aw.
Your sister is expected to have an expected. That's really exciting. Now, is Leah far enough along where she knows she has to do more, or they don't want to know? Or
They're gonna find out. It'd be like end this month or beginning of May.
Okay,
They're gonna find
okay.
out.
how far along is Leah?
I think she just started second chemistry.
Because in the picture, she wasn't showing at all.
Yeah, she's not showing that much, but she just started second chemistry.
Okay, can you tell?
Yeah, I'm a little bit. so-
Yeah, because you see her. You see her.
Right, but it's not that.
Yeah.
Yeah.
Have you taken care of any heart failure patients here? Have you seen some of these meds? Oh, good, okay, okay. Have you administered them?
Yeah.
Which one? Very inexpensive drug. One reason why it's used a lot.
You said it's inexpensive?
I'm sorry?
You said it's inexpensive?
Relatively inexpensive, yeah. Even the sustained release one. Let's talk about- 30-day supply, generic, is $30. For an extent, for sustained release formulations are usually quite expensive, that's cheap. That's pretty cheap. This propofol month supply is $26. Generic carvedilol month supply is $5. Very inexpensive. If you get the extended release carvedilol, that gets a little pricey, that's $200. Entresto, because it's still under license, is still pretty expensive. Entresto, a month supply is about $500. So that's an expensive medicine.
Dr. B,
Yes,
do you know where you have your what we're about to go over? Do you know where you have that?
oh, that some people I don't think got the antiarrhythmic handout, which I have because they were on the printer, but I brought them with me today, so if you didn't get one, say boo, and I'll. I guess I don't know.
Are you scared yet?
Yeah, that one. That one.
Oh, I didn't scare you. Poor guy. Well, is it? Okay. No, I can say this.
You got that, okay. Sherry, did you get?
Yeah.
You got one? Okay.
I think so.
Yeah. All right. All right, does anyone have any cleanup questions about treatment of heart failure? Bosentan is used in the hospital. It is only available parenterally. It is a mimic of atrial natriuretic peptide. It's essentially meant to give you a quick afterload decrease. It's used for acute cases. If you use it too much, it will tend to, it can tend to affect the heart adversely. So it's only used short term. It's a relatively new drug. It's kind of expensive. But there are times acute wise, it can be very useful. Can tend to slow the heart down, and that when you get patients who are already on beta blockers, slowing the heart down a little bit might not be a big deal, but if you slow the heart down too much, you can start to have trouble. You get heart blocks and stuff like that. There's another drug at the bottom, Versaguat. That drug is very new. So there's really not much research on that drug. As research starts to come out on that drug, the initial phase 3 studies looked quite hopeful. So there's just really not, I put that on there essentially because you guys will probably end up using that more and more. I still remember the first class, and Entresto was very new. I talked about it, and now they're all seeing it in the hospital front, left, and center. So it's a good thing we talked about it. All right. Any more questions about heart failure? Anything like that? All right. Let's go to arrhythmias. Arrhythmias. Okay, this is not simple. This is did you get this handout last time? No?
I didn't get one last time, no.
I'll tell you what, follow along and I'll email it to you after class, okay?
Okay, thank you.
Anti-arrhythmic thing on your Blackboard, it's not this exact,
Right, this is updated a bit.
but she could probably like edit it out.
Grace just told me that there is a version of this on Blackboard you can download, and then you can amend it essentially as we talk about it.
Okay. Sounds-
It's under the handouts, which is under, I think, basics, course basics or course materials, or I forget which one. It's on Blackboard, you'll find it.
Okay, thank you.
Okay. Arrhythmias. So if the heart beats too quickly or too slowly, or if it beats erratically, that is an arrhythmia. If the heart beats too quickly or too slowly or erratically, I guess you could say irregularly, that is an arrhythmia. Arrhythmias can originate in the ventricles or in the atria. If they originate in the ventricles, they're called ventricular tachycardias or ventricular arrhythmias. If they originate in the atria, they're called supraventricular arrhythmias. So to understand how these drugs work, I need to take you back to A&P and talk about the action potential of a cardiomyocyte. Now, hopefully, this will start to shake some cobwebs off from your memory. So, cardiomyocytes have a resting potential of somewhere around minus 90 millivolts. When they are stimulated, how are they stimulated? Remember that your cardiomyocytes are connected to each other. What's this connection here? What's that structure called? In the microscope, between the cells at high power, you can see these little dark bits between. No, the striations are actually in the. These are between the cells. You can see them pretty clearly in a good slide. They're decorated with junctions, yeah. This is called an intercalated disc. Remember that? And the intercalated disc is decorated with these gap junctions. And Shay, I think that's what you were thinking of. There's thousands of these gap junctions. These gap junctions essentially means these cells are functionally connected. Any ionic change in this cell spreads immediately to this cell. So if you get an increase in calcium or sodium in this cell, it spreads to this cell. So when you activate this cell, it starts to become more non-negative, starts to become more positive, because more positive ions are leaking into the cell. When the cell gets to minus 70 millivolts, it's going to depolarize. You're going to get the opening of the so-called fast sodium channels. Fast sodium channels. You get rapid sodium influx. That's why they're called fast sodium channels. These are the voltage gated sodium channels in cardiomyocyte membrane. Sodium goes rushing in. You depolarize the cell very quickly up to about plus 10 millivolts. When you get to about minus 20, you open a second set of channels called L-type calcium channels. L-type calcium channels. Those L-type calcium channels will stay open. You also open voltage-gated potassium channels. You get up to here, the fast sodium channels close. That's called phase 0. The fast depolarization is phase goose egg, phase 0. Remember this by, oh my, that depolarized quickly. Phase 0. Now, you now have potassium leaving, calcium entering. Because of this, you get a slight depolarization. That slight depolarization is due to the outflux of potassium, but calcium's coming in too. Because of this, you're going to get an equalization. This fast depolarization, that's phase 1. Phase 1, because potassium is plus 1. And then calcium, which is plus 2, is fighting with the potassium. That's responsible for stage 2, the plateau phase. The plateau phase. Now you get right about to 0. Right about 0, just below 0, the L-type calcium channels shut. And now you depolarize by virtue of the voltage-gated potassium channels. Potassium leaves, you're now in phase 3, and you go to resting potential, that's phase 4. Grace?
And phase 0, like when it's going up, if that's depolarization,
Yep.
what if 2 and 3? What if happens?
2 is a plateau. The cell is in the sorry, I lived in England for 3 years, it still infects me sometimes. The process of depolarizing, but you have this fight between calcium and potassium.
Wouldn't it be repolarization though?
Right, it's repolarization.
Oh, okay, sorry.
Yeah, it's in the process of, right, it's the darn mask, repolarization.
Got you. Okay.
And it's only when the calcium channels close that potassium is able to bring it home. And how do you remember 3? Calcium is 2, potassium is 1. 2 plus 1 is 3.
So which one was repolarization?
Repolarization is from here to here. 1, 2, and 3. But the fast repolarization, that's due to potassium efflux. But those calcium channels, L-type calcium channels, have opened. They opened over here. They started to open. Then by here, they really open. And it's really here, you start to get the calcium-induced calcium release inside the cell. It's here, you're going to start to contract. So contraction is going to look more like this. Essentially. Then you get to phase 4, that's your resting potential, and then the whole thing starts all over again. All right, any part of that That kicking the cup, you kicking the rust loose at all, or? Okay, Natalie's like this, others are not sure how much rust is there. So, okay, yes, good, move on. Because if you don't get this, the rest of it's not gonna make a lot of sense. All right, class 1 antiarrhythmics. Class 1 antiarrhythmics inhibit fast sodium channels. They inhibit fast sodium channels. There's 3 types of class 1s. They're called class 1A, class 1B, class 1C. Class 1A, class 1B, class 1C. All right, let's take a look at the class 1A drugs. These are moderately effective. Moderately effective. Class 1 drugs work in the myocardium. They don't work in the conduction system. They work in the myocardium. So they're not going to affect the nose. They affect the myocardium, and they're going to affect essentially this electrophysiological profile. So these drugs then are going to take the slope of this fast depolarization, and they're going to kick it this way like that. They're going to slow that down like that.
So it's slowing down repolarization?
It will, so that slows down primarily depolarization.
So that sodium influx, that's what it's.
Yeah,
Okay.
but because sodium comes in more slowly, repolarization itself is also slowed down a bit as well. Now, when patients are on these drugs, hook them up to an EKG and watch that EKG carefully. Okay, do you see my cute little squirrel here? Notice it is a cutie. So cutie means that it increases the QT interval. It's a cutie. Okay, I know it's stupid, but
That's for your next class, okay?
oh, okay.
The class of
Well, the cutie, the QRS, it looks a little like the tail of a squirrel. So that's the other thing, the reason I put the little cute squirrel. So it's a cutie. Right. All right. There's 3 drugs here. There's quinidine, there's disopropamide, and there's procainamide. Now, quinidine, disopropamide are oral. Procainamide is oral, but it also comes in an IV form. If you work in the ICU, you will use procainamide. Won't use it all that often, but you will use it. So watch the QRS complex, watch the QT interval. These drugs can prolong the QT interval. And if your QT interval becomes more than 500 milliseconds, you're at risk for torsade de pointes. And the ribbons there, that's meant to symbolize torsade de pointes, because that's a little bit what torsade de pointes looks like on an EKG. So when you see the ribbons, that's torsade de pointes. When you see the little cutie, that means long QT interval. How do I spell what? Torsade de pointes is on the handout. It's, yeah. What are these drugs for? They're for atrial fibrillation. They're for atrial flutter. They're for ventricular tachycardia. They're particularly good for ventricular tachycardia. And they're also for supraventricular tachycardias. Side effects besides the cardiac ones. Quinidine causes synchronism. So you get headaches, tinnitus, and blurry vision. What's tinnitus? Somebody answer the phone from Seinfeld. Seinfeld's father. Somebody answer the phone with tinnitus. Disopyramide is an anticholinergic. That means you're going to get dry mouth, dry eyes, urinary retention. Procainamide, long-term use, you start to see ANA, anti-nuclear antigen. That's indicative of systemic lupus erythematosus. That goes away when the drug is discontinued. So my dumb little mnemonic, think of a pyramid with a disco ball on top. Disopyramidine. And then an Egyptian queen, Queenadine. And she's blind and holding her head because of the disco music. And she has ringing in her ears. Then for procainamide, think of a wolf. And by the way, procainamide is a drug of choice to treat wolf Parkinson White syndrome. So think of a white wolf. And it also causes lupus. So think of a white wolf. Okay, I know it's stupid. That's the point. They don't like my mnemonics, Emily. They're making fun of me.
I think they're great.
Oh, you think they're great? Okay. So I'm getting some love here from Emily. Unlike some people. Yeah, Natalie. Yeah, A with 1As. Yeah, 1As. Correct. Any questions about the 1As?
The class, well, not necessarily one A, but do just class one antiarrhythmics. Slow down depolarization, or is that all antiarrhythmics?
All the class ones, that's their target. They do it to different degrees, but they all inhibit the fast sodium channels.
All of class ones.
All class ones.
Okay.
That's their target. Yes, Sydney?
So if I see a long QT, I need to do what?
Well, where are you?
No, like you just said, like watch the EKG.
Yeah,
So if there's a long QT, do you do anything about it, or? is
you
it
may
just
need to
like-
discontinue the drug.
Okay, there's nothing you can do like for like
Well, if they go into Torsade de Pointes, what's your treatment for Torsade de Pointes?
make salt push.
Max sulfate push, so make sure you've got max sulfate very close by. If they go into Torsade, that's what you give. Because Torsade can become asystole pretty quickly, so.
Okay, but the longer QT, you just discontinue.
A longer QT, if it's less than 500 milliseconds, is not that big a deal unless it starts to really elongate. And usually what you see with a patient is it'll elongate, then it'll get a little longer, then it'll get a little longer, then it'll get a little longer. And if you start to see that, then you tell the provider that you're seeing this. And the provider may say, okay, if it gets to such and such, then pull the drug. Okay, 1Bs. Can I go on to 1Bs? 1Bs are the weakest of the class ones. So their tendency to cause torsade de pointes, their tendency to elongate the QT interval is quite low. Can it happen? Yes. Is it common? No. So these are not going to change the EKG. There's two drugs in this group, lidocaine and mexiletine. Toconide is another one, but toconide's not used that often. So again, my dumb mnemonic, mexiletine causes GI upset. So think of a lid, garbage can lid, lidocaine with a taco on it. Mexiletine. And if you eat the taco, you'll get a stomach ache. That's what happens if you eat tacos off garbage can lids.
Oh my gosh. Oh my God. Wait, what does taco have to do with mexiletine? How does taco relate to that?
Mexiletine.
How long on average does it take you to come up with?
Quite a while. Some of them I had help from other sources, but some of them, yes, are mine and mine alone.
Have you
So.
ever told your wife these?
Yeah, she says, I don't get it.
It must be so new.
Say again. Lidocaine is only given parenterally. Now, the issue with lidocaine is it's lipophilic, so it can enter the CNS. So you can get, that has some neurotoxicities. You can get quivers, tremors. People can have seizures on it, especially if the concentration gets too high. Lidocaine you never want to use for very long. It is the drug of choice for digoxin toxicity. These are used only for VTACs, ventricular tachycardias, essentially. Lidocaine, by the way, when you give it, you tend to give it in a bolus. And you give it in a bolus. I think it comes 1,000 mg per 250 mils. It's usually in D5W. And you bolus it every 3 to 5 minutes. You give them 3 boluses max. 1 to 15 mg per kilogram body weight, I think, something like that. Yeah, so. Okay. 1Cs. 1Cs are the most potent of the class 1s. For that reason, you're only going to use 1Cs for life-threatening ventricular tachycardias.
Why is that? Oh,
Because they're very potent. And on page 3 of the handout, there's some tracings of electrophysiology, and you can see what each of these will do to the electrophysiology of each of these, to give you an idea. So there's 2 main drugs here. There's flecainide and propafenone. Flecainide and propafenone. These drugs are usually not dripped. So you usually won't use these in the ICU. They're not dripped usually. They're just given orally. I don't even think they come in parenteral preparations. So they don't cause QT elongation, but therefore your ventricular tachycardias that have progressed to ventricular fibrillation. And you usually use them for things that don't respond to other treatments. And these drugs are the ones most likely to cause cardiac death. This is especially true in people who just had a heart attack. Okay, 2 drugs, flecainide, propafenone. Propafenone causes a metallic taste. So my dumb mnemonic is a flea-ridden dog chewing on a propane tank. It's a metal propane tank. The metal propane tank, propafenone, causes a metal taste in the mouth, and the flecainide, the canine has fleas.
That's a good one. You kept it short, it's good.
Okay, yeah, good, so,
Best one so far.
oh, okay,
10 out of 10. There you go.
okay.
I see taco, which is
You didn't like that one, okay, well,
Dr. P, why are these not given orally? It seems like it sounds like.
they are given orally.
Oh, no, like, why are they not being given like through an IV?
They're not given through, well, the one seeds, they're not given through an IV, usually, because they're just not given that often. And so developing a parenteral form of it was just not worth it for the drug company. There wasn't a big demand for it. That's probably the biggest reason. Lidocaine is just a drug you can't really make in a pill form. It's already liquid, so that's essentially why it's already in liquid form. Same thing with quinidine, same thing with these others and what have you. Has to do with essentially the type of chemical it is and what form it usually comes in. Okay. Any questions on the class ones? 1A, 1B, 1C. If it helps you remember these, you're at the beach, you see 3 buoys in the water. The beach, remember, salt water. So it inhibits the sodium channel, salt water. 3 buoys, the A buoy, the B buoy, the C buoy. Natalie looks like she's ready to throw something at me, so I'm going to stop. All right, class 2s. Class 2s are your beta blockers. Beta blockers can serve as antiarrhythmics. So they are going to depress conduction through the AV node. So these are going to affect mainly conduction tissue. So with these, you're going to watch the PR interval and you're going to watch the heart rate. Because these can cause bradycardia, they can cause hypotension, and they can cause an AV conduction block. So be familiar with Mobitz 1, Mobitz 2, so on and so forth. Mobitz 1, Mobitz, did you cover Mobitz 1? No. Right, the PR interval, heart rate, and then make sure you watch the EKG for signs of an AV block. Okay, AV blocks, very quickly. Here's the Reader's Digest version of AV blocks. Okay, P, Q, R, S, T, P, Q, R, S, T, blah, blah, blah. All right. So the type or the first degree blocks, it's not a block, you have a delay. So there's a delay between T wave here and the start of a new P wave. You just have a delay. That's the first degree AV block. The AV block essentially transmits the signal from the atria and the AV node slowly. That's a first degree block. Second degree block, there's two types. There's what's called a Mobitz 1 and a Mobitz 2. Here's the difference between a 1 and a 2. By the way, first degree blocks usually are asymptomatic. Don't need to treat them. With a Mobitz 2, this interval between the end of the T wave and the start of the P wave gets a little longer, little longer, little longer, little longer, and then there's no QRS wave. Then you get a normal EKG, then that interval gets a little longer, little longer, little longer, little longer, then it gets dropped. So it gets progressively longer, then you have one beat that doesn't get through, it gets dropped. That's a Mobitz 1. Mobitz 1 is usually asymptomatic. Usually. Mobitz 2, you have a normal beat with a normal rhythm, but out of the blue, you have no QRS complex. You just have a P wave, no QRS complex. Instead of the progressively longer delay, you just did everything's fine and then no QRS complex. The heart skips a beat, if you will. Third degree block is a complete block. In this one, now the bundle of His usually takes over and generates a beat for the ventricles. So the P waves and the QRS waves are completely uncoordinated. They have little to do with each other. And that one needs to be treated, usually with cardioversion or pacemaker or something like that. Mobitz 2 needs treatment too, because a Mobitz 2 can become a third degree. Does that help? Okay, so these block that beta 1 adrenergic receptor. They're going to prevent production of cyclic AMP. They're therefore going to prevent phosphorylation of the L-type calcium channel, blah, blah, blah. They decrease oxygen consumption. By the myocardium, they lower the heart rate. Now, with your cardioselectives, usually you prefer bisoprolol and metoprolol, usually. Metoprolol is given as an IV push. There's an oral form, but it comes in a form that's given as an IV push. It's not given as a drip. Same thing with propranolol. Propranolol comes as an IV push. It's usually oral. Doesn't come in a drip form. The one that does come in a drip form is esmolol. Esmolol comes in a drip form. Because these inhibit catecholamine-induced tachycardias, they're very good for catecholamine excess arrhythmias. They're good for atrial fibrillation. They're good for supraventricular tachycardias, particularly ones that originate at the nodes and what have you. And you've seen the side effects before. We don't need to go over those again. This is important right here. So they're contraindicated on patients on calcium channel blockers. They're also in patients with pheochromocytomas. Pheochromocytomas are tumors of the adrenal medulla. So they hypersecrete catecholamines. The beta blocker blocks beta 1, and then they can block beta 2s at higher doses. Or if they're non-selective, they'll block beta 1 and 2. That means all the catecholamine goes to the alpha 1s, and you get massive vasoconstriction. And that massive vasoconstriction will jack the blood pressure up to dangerous levels. And the antidote is for overdose is atropine, saline, glucagon, so on and so forth. Questions about the beta blockers? Because these slow the heart rate and they slow the rate of conduction, they're very good for tachycardic types of arrhythmias. All right. Class 3s are the most difficult of this group. And we're going to encounter this drug, amiodarone. Amiodarone is the most widely used antiarrhythmic. This drug is also a pain in the butt because it has a very long half-life, has a lot of side effects, it interacts with everything, but it's really useful. So we'll go over amiodarone on Wednesday, finish this, then we will get into the antihyperlipidemics, treatment of angina, and then the anti-clotting drugs. That's the roadmap where we're going. Okay? Have a great evening. See you guys on Wednesday.
One is, can I do the extra credit for